All right, it's all you, Mary.
Okay. Well, welcome everyone to this different kind of meeting. I'm so glad so many of you can make it. So we have our Community Services Board here on Zoom, and there'll be mental health staff who are present too. And then we have members of the subcommittees and other community members on the YouTube channel. So we're getting quite a lot of participation. There was a couple of announcements that I need to make before we actually start. You should all know that this meeting is being recorded and streamed live. And it's very helpful if when you're not talking to please mute your ability to speaker thing, the thing at the bottom there. So that would be really helpful to the discussion. Just wanted to mention that in this really critical time that we're all going through and experiencing, it's so helpful for us to come together and have a sense of what's happening in our community, what's happening with the services that we're responsible for. So I really appreciate the mental health staff and obviously Frank's involvement in pulling this together, and all the folks who are behind the scenes making the technology work so well. I really appreciate that. So the meeting is primarily going to be reporting from Frank and the staff at the mental health department. And there's adequate time in the agenda for us to ask questions afterwards. So I'll turn the meeting over to Frank.
Great. Thanks, Mary. And thanks everybody for joining us and those that are listening on YouTube. We did invite all of the subcommittees and the guests that normally come to those meetings so they could listen to this update about where we are. We will be having those subcommittee meetings this month. So we were hopeful we could do this once and then get into more detail on the different areas of interest in the subcommittees to save some time for them. So thank you everyone for participating. I also want to echo the thanks to our ITS department. They've done an amazing job, not only getting this meeting set up so that way we could continue to do this, but what they've done for our department and working with leadership there to essentially turn telemedicine on in a matter of a couple of days was nothing short of phenomenal. And you'll hear a bit more about that, but I want to thank Greg and Lauren publicly for their work and their team's work. I also want to thank the team at Mental Health. I haven't been there. I've been up here and I'll talk a little bit about what's been going on with that, but Jeremy and Susan and Jed and Heather and Maria and all the folks at Mental Health have done an amazing job under amazingly stressful and unprecedented. We say that so often, but we've never been through something like this, and to be able to dedicate the time and energy it was necessary to get ourselves back operational for the people that we serve was nothing short of miraculous, and they're to be commended for their leadership and ability to make that happen. So I wanted to take a few minutes to talk a little bit about COVID-19 in general and kind of what I've been doing and where we are today, talk a little bit about reopening because I know that's what's on everybody's minds. And then I've asked staff to join us to talk about how the three programs in the department are operating and what they've been able to do to stand up services. And then we'll, like Mary said, we'll make sure we have time for questions. If there's any questions we can't get to or we run out of time, we'll make sure we try to get those in. I'm gonna mute everybody. All right, so I muted everybody. If you want to talk later, you'll have to unmute yourself. So where are we with COVID-19? Obviously, this has been going on for a while. The health department, we began our work 7 days a week all the way back to the last week of January when we were looking at travelers from China and doing quarantine for those folks returning. Early on, because of the international travel related to our higher education, we had persons under investigation all the way back in the first week of February. So we've been dealing with isolation and quarantine now for what, February, March, April, 3 months. Seems like a lifetime, but it has been going on for a while. Obviously, it evolved from there to having active disease in the US and then potentially in our community. Kind of a watershed moment for me in all of this was March 13th, where I made the recommendation to the county administrator that we close the K through 12 schools here in Tompkins County. It doesn't seem like as big a deal now, but back then we were the first county to do that without having a case in our community. And so it was a big decision that needed to be made. And ultimately, I think it turned out to be the right one, but it was probably the biggest decision we made from a community perspective throughout this whole situation. Obviously, things have evolved from there, and we've done a lot of disease tracking. We had a peak a week or so ago now, where we had a couple of days where we had 12, 15, 16 new cases. Thankfully, I can report we've had a few days with no new cases now. I think it's 3 in a row. We only have 2 hospitalizations currently. So the incidence of disease here in Tompkins County is relatively low. And that is a credit to the community and the steps that they took. It was hard. Not everybody was happy about it, but folks have been compliant. They're staying home. The businesses obviously closed that needed to close, and a lot of people are taking pretty dramatic steps that it has been challenging for them, both financially, socially, all of the things that we're all working through, and they've done it because they knew it's what we needed to do to protect our community. And so I'm extremely thankful to live in a place like Tompkins County where folks took this so seriously. In the midst of all of this, much of what we've been doing here at the Emergency Operations Center, or EOC, is coordinating all of the good work that's happening out in our community. We started in the very beginning dealing with food and trying to make sure that food was available. Our school districts, FoodNet, or our Meals on Wheels program here, and the Southern Tier Food Bank have done amazing things to get amazing amounts of food out. There's been grassroots efforts that have set up, food drop banks in some parts of the county where people can just go to these blue cabinets and grab food out if they're in need. So there's been huge amounts of work around that. We've done a lot of conversations around daycare, trying to make sure daycare was available for essential workers here in the community. We had some calls early on with our mental health and substance use providers just to make sure they were all on track and had what they needed. And obviously our team will talk more about what we did, but the Drug Council and CARS quickly shifted to telemedicine. CARS put procedures in place for their residents, and really, without missing too much of a beat, continued to provide services to our community. Family and Children's went to telemedicine, as did many of our mental health partners in the community. So they're all to be commended for what they were able to do. If you haven't seen on the mental health webpage, as well as on the public health webpage, there is a list of local resources related to mental health services with what services they have available and how to contact them to access them. So that's all in one place where people can look to get that. As of late, a lot of the conversation has shifted to reopening. If you're not aware, the governor has outlined a plan related to a regional approach. And we are part of the Southern Tier region. So there's these things called the Regional Economic Development Councils, or REDCs, I learned that they're called for short. I thought it was because all those, Republican states were along the border and it was Red Sea, but I was quickly corrected. So the Regional Economic Development Councils are the kind of the region and the approach that the governor has taken. We've had conversations with leadership here in Tompkins County at the highest levels. We've been talking with the county executives and county administrators of all of those counties, trying to coordinate our region's approach to this. The important thing to know is the governor, pretty much since the day after we closed the schools on March 13th, he took complete control of the response. And so both from the metrics that we're going to use for reopening, as well as the phases of who's going to be allowed to reopen in what phases, that's all being directed by the governor. But what we have the opportunity to influence is, one, the disease in our community. And thankfully, because of the work of Cuyahoga Health Systems, we have testing capacity here. And quite frankly, they have spoiled us. What we have available here is not available in much of the rest of upstate New York. In fact, the state just set up their drive-throughs this past week, right? And so we've been doing this because of Cuyahoga Health Systems for 5 weeks now, almost 6 weeks. Their ability to stand up testing really helped us be able to identify cases early, get them isolated, and limit their exposure to other people. So a lot of credit needs to go to Cuyahoga Health Systems. And they are now in the process of going to nursing homes and adult living facilities and doing testing in those facilities in the absence of known cases, to do some surveillance so we can find out if there's unknown cases that might be problematic. So they've been a super partner and have been with us every step of the way of trying to address this. And so because of that testing capacity, we're able to tell the state we can meet all of those metrics that the governor has outlined. Most of the other counties can meet all of the metrics. Most of the other counties in our region can meet all of the metrics except for the testing one. The governor wants he wants the county as a whole to be able to test 30 people per 1,000 every month. Which for us would mean 3,000 people needed to be tested a month. And that's about what we did. And we are way ahead of all the other counties. So there's some work to be done around testing for our region, but we're still confident when phase 1 comes, we'll be able to move forward as a region. So there are conversations going on with higher ed. We actually had a meeting with them this morning to try to coordinate their efforts, because obviously if Cornell does something, it's going to impact TC3 and Ithaca College. And really from a disease perspective, it's better if we do it in a coordinated manner and support them as best we can, because while bringing students back will challenge us from a disease perspective, it is also a challenge for us as a community if those students don't come back. It would be economically devastating. So we're trying to make sure we're giving them all the support and information they need to make the best decision possible from a health and safety perspective, while getting us back to whatever the new normal will be as soon as possible. We've also been communicating with industry as part of those conversations to find out, as they're bringing back, what might they need. Cuyahoga Health has agreed to expand their testing capacities to be able to help in whatever manner might make sense from a reopening perspective. I want to talk a little bit about testing in general, because we get a lot of questions about that, particularly about antibody testing. So the testing that's been going on at the drive-through and that we're primarily conducting is called PCR. I don't even remember what it stands for, but it's really the positive negative test, and it's a swab of the back of your throat or the back of your nose, right? And it's not a pleasant thing. They're tickling your brain with that swab. It's not just to let me rub the inside of your nose. So it is somewhat unpleasant, but it is a positive negative test, and it is a snapshot in time. So at the moment the swab is collected, it's telling us whether or not you had COVID-19 virus that was collectible in your body. So that's primarily what we're doing. And what that test allows us to know is if someone is currently sick with COVID-19. And if they are, then the health department staff do what's called contact tracing, right? So we'll isolate the individual that's sick. We interview them to find out everywhere they've been, who they've been in contact with, going back 48 hours prior to the onset of their symptoms. And then we reach out to all of those people and we give them instructions on what they might need to do. And mainly quarantine. In some instances, as you've seen with Wegmans and the Rabbito gas station, if we're not able to identify everyone that was a potential contact, we do a press release and we essentially tell the community, hey, if you were in these areas during these times, you may have been exposed. And so to date, the Wegmans exposure drove our biggest test day. And one day we tested 450 people. So that was a big lift that CHS was able to accomplish for us. Thankfully, those were all negative. So it was good news, but it was well worth knowing whether or not we had cases. We will continue to do the PCR testing or the positive negative testing going forward. That's our main tool from a stopping the spread of the disease perspective. And that's one of the key measures for the governor when he's talking about testing availability. That's the testing he's talking about. The antibody test is still new. There's lots of versions out there. Some are not as good as others. And so we haven't been promoting individuals get antibody testing yet because we want to make sure that if they do, they're getting it from a reputable source and can trust the result. Unfortunately, we don't even know what the result means yet. We will at some point in the future when enough study can be done on the disease. We'll know what having positive antibodies means, but we don't know that right now. So really today, what an antibody test tells you if you're positive was that at some point you were exposed to and had COVID-19. Right? Whether you had symptoms or not, or even knew it, you have antibodies in your body, and we know that. What we don't know is there any protective factor associated with that? Does it mean if you have antibodies, you can never get COVID-19 again? Does it mean, well, you might get it again, but it might not be as severe? Or does it mean nothing, that you could have had exposed and get it again? We just don't know the answers to that yet, but we will. And so there is some antibody testing going on, mostly being ordered by physicians and mostly being ordered by physicians at nursing homes. So if the effort is being taken to go into a nursing home to do the PCR testing, at that point, it's almost worth doing the antibody testing to be able to say that it was done because we were already there and to limit having to go back and potentially expose the clients there and other. There's also antibody testing going on with healthcare workers and others that have had known exposures or have had COVID-19 in hopes of retrieving plasma from them. So there is some positive results from using the plasma of individuals that have antibodies for treating those that are currently sick with COVID-19. So that's another reason that antibody testing is being done. But we're not yet widely requesting that folks do that. So that's kind of where we are. You know, we get a lot of questions about our summer camps going to open. Is there going to be summer school? Is there going to be school in the fall? Or is Cornell opening in the fall? We don't have answers to any of that. And the governor said something a few weeks ago that I've really been holding on to, that, you know, if you're asking about what it's going to be like more than 2 weeks from now, we don't know. Right? We just don't know. Things are changing too quickly. And every day it is no exaggeration that from hour to hour, what we're going to be working on here in the Emergency Operations Center is changing based on what's happening in the community, what the governor is saying, or what the disease is doing. So it is just too hard to know. And with the governor really making all the decisions on these, every day we're watching his press conferences to find out what's next, right? We don't have any particular insight that others don't have. We are glued to the TV watching those to see what we need to get working on for the next 24 hours. I wish I had answers on a lot of those things because everyone is asking them, but we just don't have them yet. So that's kind of my quick and dirty, update of where we are on COVID-19. I will just offer that I have been working up here in the Emergency Operations Center at the Department of Emergency Response pretty much since March 13th. We have a team of folks here. It's small in the building because we're social distancing, but there's usually 4 or 5 of us here every day, including the county administrator. Amy Hendricks, the deputy county administrator, has been leading the EOC. Jay Franklin from assessment has stepped into planning. Jessica Furvis from Dewar is our logistics, making sure our supplies get ordered and pushed out. And Drew Brahman from our finance department has been handling the finances part. We do have an amazing public information team You guys probably have seen what they've been doing. We are extremely popular on Twitter and Facebook now, and our website. So it's going to be sad when we go back to 10 people seeing our Twitter things, but we're reaching tens of thousands of people now through social media. We're averaging over 100,000 views on the health department webpage each week. And so it's been a huge undertaking, and we've had 7 or 8 people on that PIO team working since the early days to get messaging out, and all the credit goes to them for their creating the messaging. All these wonderful quotes that I have, they make me sound really smart because they're writing them, and I'm just saying, oh, that sounds really good, go with that. So it's nice to have people that literally put words in your mouth that make you smart, look smart. So they've been really good, and we've certainly recognized the value of being able to dedicate that much resource to public information, particularly in an event like this. So I offer all of that just to say we've got a cross-sectional team. That PIO team has 5 different departments represented on it for the county. Really what has happened is people have stepped in. Wherever we needed something, we asked, and people have stepped up. And that's really been the reason for much of our success, is we have great people that work for the county, and that our community partners that have stepped in when we've needed them. And with that, I'll transition because that goes perfectly well with what's happened at the mental health department. There's an amazing team of people there that I walked out the door one day, and I don't think they saw me for a couple of weeks, but in that couple of weeks time with Jeremy and Susan and Jed, Heather and Maria, they were able to transition to a telemedicine approach for everything that we do, while still maintaining crisis services, injectable medications, and medication management, all in the midst of a worldwide pandemic that was potentially putting them and their families at risk. So I can't say enough great things about the work that they've done, and I'll stop talking and let them share with you kind of some of what we've done, what they've done at the department. Susan, I think you were gonna kick it off with the clinic.
I'm to start.
Yes.
Hello, everyone. I'm Susan Spicer from the clinic, and so from day one, we have managed to continue our clinic services. We had 1 day of interruption, and even on that day, we were still providing some services. The majority of our clinicians are working from home. They're providing telehealth. We have a small group of staff that is in the building, and we rotate a bit. We're providing injectable medications, and we quickly implemented a protocol for what to do with clients who come in the building, because we're mental health and clients come into our building. And so we are, as I said, are providing the majority of sessions by telehealth. We even restarted a few weeks ago our groups by Zoom session. What am I forgetting? Our crisis services are happening the same as they typically would. Crisis during the day is covered in the clinic, and then evening crisis is accessed through our suicide prevention. So all of our services right now are up and running, and have been for several weeks now. I wonder if Jed Lippert wanted to join to talk about services that the medical staff are providing. You have to unmute yourself, I think, Jed.
There we go. Okay,
There you
yes,
are.
I'd be happy to do that. I'm Jed Lippert. For those of you who don't know me, I'm the medical director of the clinic now and acting DCS. My purview is to ensure that the medical psychiatric services are of the best quality despite the crisis. And that's been a challenge. There's a number of factors going on that really have nothing to do with the crisis, which are making it even more of a challenge, which I could mention later. But we felt originally one of our priorities was to maintain injectable medication services, long-acting injectable medication for the clients that are currently receiving that treatment. And all the literature suggests that people who are stable on that form of treatment are going to do better long run by maintaining the treatment. And of course, the challenge with that is that as much as telemental health can be delivered quite effectively through Zoom or telephone even. Injections cannot be given. I mean, there's no way they can be given except by intimate person-to-person contact within the clinic. And so we had a lot of meetings, Susan, me, the other nursing staff, working out a way of making sure that the clients were protected, and more importantly, well, equally importantly, the staff were protected. There was a bit of a struggle early on getting the adequate PPE, which we consider to include an N95 mask. Obviously gloves and to some extent gowns were fairly easily available, but the masks were not. So we went without them for a little while, but we got them fairly quickly, thanks to the intervention of the health department. And we didn't miss any injections. We've done very well. Some people have chosen not to continue, but anyone who wanted to continue, and we certainly encourage them to, has been able to. Psychiatric, we've been doing psychiatric assessments as usual. Well, they're not usual. They're over the phone, they're remote, or by Zoom. We've been doing follow-up appointments. There was a little bit of sort of a period of time when we were not able to do as many as we probably wanted to, but we quickly got up to speed with the help of Jeremy, front desk staff, scheduling, ITS, of course, and we've got full schedules now. Right now, the full-time medical staff includes myself and our nurse practitioner, Patty Zalewski. We have a part-time psychiatrist, which is Tim Lowry. One of our long-term psychiatrists coincidentally left right in the midst of this pandemic, which was Karen Miller. So one of the challenges that we have right now is maintaining adequate treatment for a lot of people who no longer have their primary psychiatrist. So we've been prioritizing the clients that she has and has had that are most needy. And we have another challenge coming up, which is that our part-time psychiatrist, our per diem psychiatrist, Dr. Lowry, will also be leaving at the end of May. So that's going to be challenges which have nothing to do with the COVID crisis that we're going to be dealing with over the next few months, as effectively as we can. So maybe I'll leave it at that. I'm sure if there's any questions, I'd be more than happy to answer them.
Thanks, Jed. Jeremy, did you want to add anything?
I think they covered it very well. I don't have anything to add.
Great, thanks. So we'll jump over to pros. Heather, did you want to give an update?
Sure. So similarly to the clinic, pros had only a short period of interruption. It took us a little bit longer to get groups up and running, about a week, until we had a new schedule created, and then also had everyone ready to be doing Zoom groups at home. We did have, even the very first day, all of our clients were contacted by our staff in that first few days. And we continued to provide crisis support as needed. People still got to see Dr. Lipper as they were scheduled. I can tell you the very first time that we were able to have a Zoom session, it felt so good to see people's faces. So even though we'd been talking to them over the phone and checking in, making sure they're okay, and they had food and they had masks and they had what they needed, the first day that we were all face to face, through a screen, it really just made me realize how much I get from our program, and having the milieu where people are hanging out all day long. And that was a good reminder, and also pushed us to keep moving. And it was hard to get all the groups up and running, but we've been able to do that. We did lose some service in March and then have started to come back again in April. And I anticipate that we'll be at a full schedule again, starting June 1st, whether we are in person or through Zoom or some combination. We wrote the schedule so that it will work across the board. So that's what is happening in pros and where pros is headed right now. Any questions?
We'll hold questions to the end, Heather, and then we'll.
No questions then.
Thanks. Maria, do you want to give an update? Got to unmute, Maria. Maria, you're on mute.
Can you hear me now?
Yes, we can.
Great, thank you. Okay, so for care management, it was slightly different. I know that this team was already mobile. So it wasn't too difficult for us to be able to grab our laptops and do everything remotely. I think the most difficult task for us was not to have the hands-on approach. Like, for example, the forms, everything that we help and assist our clients with filling out, we don't have them in front of us. So it was very, very difficult with that segment. However, just like Heather, and I think that she expressed it really well, that once we started having access to Zoom, I think that not just for the clients, but for the workers too, just everything started falling into place with organization. For example, the supervisions are able to be done weekly. We're contacts daily. We're able to contact clients that have the ability to have the Zoom. And we have had some reports from clients that it really has made a difference, especially with their levels of anxiety. It's just good to see that face at the other end of the screen. So that's a plus. I don't want to call it an issue, but it's just challenges is with the Department of Health. They themselves have put out, compliance that we need to follow by. Everything is done telephonically. Everything is done, again, like I said, via Zoom. Everything is done still via mail. We also are able to utilize a small pot of money that we have, our rep funds, because we've encountered a lot of our clients during COVID-19 have had some emergencies, especially financial. So whenever someone calls us and says we're out of food, we're able to say, okay, if you meet criteria, come and grab this next couple of hours. We can mail it if it's not something that's so imminent that they need to have within the hour. If it is imminent, we've made arrangements internally within the building that we can be able to go outside of the building, of course, with everything on, the mask and everything else, and just make sure that we facilitate what they need, just to make sure that they don't go without. So I think that was pretty neat to have the rest of the team back us up on that. The other piece too that I want to mention is that we are via Honey, Health Homes of Upstate New York. They themselves have also put out this COVID-19 guidance, and they're making sure that that's followed to the letter. And that's because it's not because they just want to make sure that we're within compliance, but because our clients, at the end of the day, their needs are being met. And I think that is their priority. That's our priority. That's TCMHS's priority. And I think that's when we all come together just to make sure that that's our number one goal, right? The other piece too that I want to mention that I think was very, very important is that although we take referrals via Honey, I contacted Honey and I said, is it a possibility that we can do internal referrals? For example, if clinicians or whomever internally in the building had an emergency, a client that needed to be referred, we started to integrate with the hospital and we started to contact the social workers, and we were able to assess them and enroll them while they were hospitalized. And I think that was a plus. It saved 2 to 3 weeks of a time frame while you waited for the referral. It just shrunk up the time and it helped the client's needs immediately. So that's just part of what we're doing.
Great, thanks, Maria. And one other thing to point out before we open up for questions, in the midst of all of this, there was new carpeting being put in the building. So that project started right before I got pulled away. And quite frankly, the building is still a little disheveled because folks haven't been able to come back and put it all together. But we do have a amazingly new, beautiful carpeting throughout the building, and facilities has taken this time to also do some painting and clean up the bathrooms a bit. So when we are able to get back there and you are able to, you'll see a different facility that's in a much better place. So when we do welcome clients back, we'll have a nice. Kudos to this team for navigating that before this started, dealing with everything that came from it. And as you heard, barely missing a beat in providing service to our clients. So I just want to thank them again for everything that they've done through all of this and are continuing to do. With that, we'll turn it over to questions from the group. Are you trying to unmute, Larry?
Where'd I go? There I am.
We can.
Hi. Can you hear me?
We can. Go ahead.
So can somebody talk about outreach to the homeless and how those services are continuing and what people here that people that are homeless are experiencing? And then I have a question about testing and people with disabilities who can't use the cab that the county has contracted with. So.
Sure. So I can start from a broader perspective, and then I can let Susan and probably Maria answer in a bit more detail from the department. As far as COVID-19 is concerned, early on, we identified the homeless population as an area of concern. And there are community outreach workers of different types from DSS, from Family and Children's and others that have relationships out there, and actually Reach Medical became a big partner. And so part of what we were initially evaluating was how would we deal with sick homeless individuals. And our initial reaction was, you know, we've got a hotel, we'll put them up in a hotel and we'll isolate them there. And we quickly found out that that wasn't going to work for them. Right. Many of them, they might stay the night, but as soon as it was daylight, they wanted to be out off doing what they normally do. And so really, we tried to take a person-centered approach, even in this, to say, okay, let's talk to the individual and see what they want in order to be successful with quarantining. Thankfully, it's only been quarantining and some isolation. We didn't end up with a positive case. So we were really talking about people that had gotten tested because they had symptoms and we were awaiting results. But we went so far as to talk about purchasing tents for people to stay where they were, if that was going to help them separate from others in the encampments. Reach Medical set up an opportunity where they had an outreach worker go out there with a tablet so that their medical staff could provide teleservices to the folks in the encampment. So really, it was a community effort to be creative about how to meet the needs of these individuals from a disease perspective, but also what was going to work for them. And so, you know, from that perspective, I think we had a plan that worked fairly well. And thankfully, we didn't see disease spread. But I'll let Susan and Maria jump in on our service side.
I don't know. I think Frank did a really good job there.
You do.
But I did want to say that we do have, interestingly, we did a little, prior to COVID-19, we did a little rearranging in the clinic so that we would have a clinician who's, the majority of her work is devoted to crisis and outreach. And so she has ongoing communications with all of the agencies in the community, including IPD, who can recognize people who are distressed and kind of send them her way. She's doing referrals and getting people connected, and really the majority of the outreach trying to see if people will connect with us. So we do have some time very focused and devoted to that, to outreach.
Yeah.
What did you want to add?
Yeah, just something similar in the care management unit, but that was months and months ago, way before COVID-19. We redesigned our team to have what we call HH plus workers. And HH plus workers they have to meet criteria. These clients, whether it's to be homeless, whether it's to be hospitalized for a certain number of times, they are our most vulnerable population. So because of it, we saw the rising need in the local community. And I went to Frank, and at the time it was Sharon, we got the green light for that. And this is how we were able to be able to service this population, but with a time frame that they didn't have to wait weeks or months. And it was something that we could do internally, like I said a few minutes ago, and it's working really, really well. I think we were able to reduce the number of the homeless population in our county just by how we're servicing them with the HH Plus services. And we're also working very closely with the worker that Sue just mentioned. She identifies the homeless as well, and then she refers them to us for assistance.
Thanks, Maria. And Larry, what was your other question?
There's been some confusion about how people like me who wouldn't be able to access the ASAP cab that takes people. We've heard that people could call 211 and then 211 would arrange for somebody to come to their homes. And then today, and I forwarded an email to you, Frank, about that, I heard from Nicole Ralston from 211 that there's still questions between the health department and CMC about how to make that happen. So I'm wondering if you can, because I also, and the email will show this, Nicole reported that a person who wasn't able to walk, the cab company driver, I assume, lifted this person from their house into the car and then lifted them back. And if that's the case, that's completely unacceptable. So I'm wondering what the status is of getting people who need testing to the testing site or connected some way to a way they can get it.
Yeah, it's a really good question, Larry. And I did see your email just before I came in for the meeting, and I'll follow up tomorrow a bit more to see what happened in that instance. So it's been challenging from the beginning. And I will say again, Cuyahoga Health Systems has spoiled us with the amount of testing we have available. And from the very beginning, we knew setting up a drive-through at the mall, while it would capture a lot of people, there would be a lot of folks that wouldn't be able to access it. Those that don't have access to transportation, those that might have mobility issues, those in the farther reaches of the county that don't have transportation.
Right.
We recognized it had its pitfalls, but it was the way for us to get the most amount of sampling done. And I'll explain a little bit about why one big facility versus going and doing it. Why don't we take the test to the people, right? For example, much of it revolves around PPE. But secondly, also efficiencies, and I'll talk about both. So for the folks that are doing the samples, particularly in the early days, and still today, if somebody is symptomatic and you're collecting the sample, you need to be wearing full PPE, which is a N95 mask, a gown, gloves, and a face.
Right.
And those are still hard to come by, those supplies. And so when you set up in a drive-through type fashion, the exposure to the individual collecting the sample is much smaller. And really, unless there's a significant event like a coughing or a sneezing that occurs, really the only thing that needs to be changed between patients is gloves. And so it allows us to do a lot more testing, a lot more sampling per piece of PPE, right? Yeah. Because PPE is such a valuable commodity, that is the reason for doing it in the manner that we designed with the large drive-through. The second piece of that is efficiencies, right? Part of the reason they're able to do as many tests in a day and get the results back within 2 to 3 days is because they've set up a system where the samples are taken from the site at the mall to a nearby location where lab staff are sorting, labeling, doing everything that needs to be done, getting them out in the mail to the laboratory that's actually going to be doing the testing. And so all of those efficiencies that they build into the process allow them to process more samples and get results back quicker. And those things are all important to us. So that's the reason for the large scale drive-through and why we haven't set one up on the Commons, for example, right? That was yeah. Early on. So to the question about transportation, we knew that was going to be problem and we started working on solutions. It took us a little longer than we thought it was going to, simply because there was just a lot of logistics. We did originally start with, can we take nurses to the people, and quickly realized that wasn't going to work. So we shifted to how do we bring people to the drive-through. After a lot of iterations and working with TCAT and Gadabout and the cab companies and other transportation folks, ultimately the cab companies came forward with a plan where they were going to put dividers in a couple of their cabs. They'd have masks and cleaning supplies, and they were ready to make that happen for us. So that was kind of the next phase of, okay, now we have a cab that can get people up there that don't have transportation. The county agreed, if necessary, to pay for those cab rides, so finances wouldn't be an issue. And so now the pool of people that we couldn't get tested got smaller, but was still a pool of people, mainly those with mobility issues that a regular cab wouldn't serve. And really, it was such a small cohort of people. We decided that we were going to handle it on a case-by-case basis with coordination through CMC and 211, and if necessary, the health department. It sounds like we may have some work to do to improve that process based off of what you've described, Larry. So I will look into it tomorrow and try to figure out where we are with that. But please understand, every step of the way, we've recognized the shortfalls of the initiatives that we've implemented, and we've tried to, as we've had resources, widen the pool of access. What I will add, though, because early on when we didn't have these opportunities to transport people, it was important for folks to know that if you had symptoms, whether you tested positive or not, you should treat yourself as if you were, and you should isolate appropriately. And so whether you had an actual test that told you were positive or negative, for the individual, didn't really mean much, because unless you needed hospital level care, in which case you would call 911 and an ambulance would come, the guidance was the same whether you were positive or negative. You should stay home, isolate yourself, treat your symptoms, and stay away from other folks until you're better.
Yeah.
It is important for us as public health folks to know about as many positives as possible so we can do the isolation and then contact tracing. But that was a long-winded answer, really, to just kind of tell everyone how that situation evolved. But I'll look into the particulars of what's going on, Larry.
I just feel like if we could have a process and then explain to people what the process is, then that will be better. I mean, it's kind of unfortunate that the cab just showed up and assumed that the only way to deal with it was by dragging the poor person into the cab and then carrying them back to their house. I mean, that shouldn't have happened, even under the process as you've described it so far. I mean, they should have been told, unless you have real concern that you've been tested, maybe just isolate yourself, or maybe contact your physician to find out what to do. I mean, nobody should have to have decided, oh, I'll be lifted down the steps and then lifted into the cab and then repeat the process.
Sure. No, absolutely. We'll check into it and improve.
Yeah. Okay.
Great. Thanks, Larry. Shauna?
Hi there. I wanted to thank the staff for attending our meeting tonight. It's been a helpful hearing from all of you. Thank you. I wanted to ask if there has been an increase in people that are seeking mental health services.
Yes. So one would think that, and we are anticipating that we will have a big increase. Right now, our intakes are below what we typically would do in a non-COVID crisis. Part of that is actually trying to get people in, try to get their, the consents done. We're doing the intakes by the phone. I can tell you that we went from about 2 or 3 weeks ago doing 4 or 5 a week. We're more in the 12 to 15 a week range. So we are increasing, and we're anticipating that will just keep going up and up.
Great. And can you also mention how long is the wait for someone to be seen by a therapist and then for someone to be seen by a psychiatrist or someone that can prescribe?
Right. So the process is that you, the intake worker will do your intake. And then within the week, you will be scheduled with your therapist to be seen. So that process is pretty quick. We have a weekly intake meeting where all of the cases are reviewed. Dr. Lippert is there, I'm there, the intake team is there, the two senior clinicians are there, and we determine, but we prioritize basically who's going to see the psychiatrist. Initially, we had some space, we had some openings, and that's tightening up. We're actually all of our physician evaluations are starting to get booked. So we have to be cautious, but I will tell you that we prioritize. We actually put a lot of work and effort into getting people in who need prescriptions, so or who need an evaluation for potential for medication. So we prioritize every week.
Thank you very much.
So potentially, by the way, it could be you could see a doctor within a week of your intake. That's a potential.
I also want to add to that, because from a care management perspective, what we're seeing is that clients that have disengaged are now wanting to re-engage because of COVID-19, increased level of anxiety, and they're calling us so we can help them reconnect to the clinic.
Can I ask a follow-up question?
Sure, go ahead.
I also want to thank all the staff for making time on a Monday night to share with us. I'm curious about whether the switch to medicine has had any impact on the no-show rate. And I'm also curious about how you're managing HIPAA.
I actually didn't hear all of the questions, so if you could ask the question again, that'd be helpful for me.
I sure can. I apologize. I'm up in the woods and the bandwidth is slow sometimes up here. My question was two-part. The first was, has the switch to telemedicine had any impact on the no-show rate? And I'm also curious about how you're managing HIPAA compliance through telemedicine. I know what we've done at Cornell has been a huge heavy lift. So yeah. I'm curious how you're managing that.
Okay, so each client is being given basically a script that talks about HIPAA and the safety about doing telemedicine. People are offered either telephone sessions or Zoom sessions. I can tell you the majority of the people prefer telephone sessions. And as far as the no-show rate, after the first couple weeks, I had a clinician who said, I never ever get a no-show anymore, because every time I call, someone picks up. Jed Lippert had an interesting observation kind of a few weeks in, which is that when people come to the clinic, they have to make an effort to get up and come to the clinic. When you call them in their home, they're so grateful that you're checking on them, and they want to engage. So for some clients, our no-show rate has decreased considerably. They're really willing to pick up the phone and talk to us. Does that answer your question?
It does. Thank you. That's what I suspected, was that the no-show rate would go down and you might get more demand on the service. Are you on the HIPAA compliant Zoom, or are you using the open public Zoom?
No, we have Zoom licenses.
Okay, because we found even with that, Cornell had a really horrific Zoom bombing incident in a group. So just for those of you that are running group, be careful how you publicize that content.
Really? Okay. I use
like horrific
practice, and so far so good. But I allow they're in the waiting room first before I let them come in. It's a small price to pay, but it gives me the control, having anybody infiltrate. I have a question for, I guess, Frank and the rest of the group here, kind of two parts. One, has the virus hit any municipal workers and staff, county workers, and given that they're now, I think in the last week, Frank, they're giving the antibody test to, I guess, a select few people. I understand it's a blood test. Are any of those folks, get a test so that they have the antibodies? They've already gone through this. And I know we don't know the effectiveness, but 9 times out of 10, if you have the antibodies, you can go amongst the public and not get the virus again. What's your knowledge, Frank, and the others as to the extent of will those antibodies, help somebody go back to work and not necessarily feel, I guess it's not 100%, but more confident that they won't get the virus?
Sure, I can feel both of those. The first question about who's been the positive cases, we've been really clear from the beginning that we're not giving information about particular cases or where they might work, who they might be, and much of that has been to protect privacy, but also we didn't want people, because we had such small numbers of cases, we didn't want folks saying, oh, well, everyone that's gotten it's been over 50, so I'm 30, I don't have to worry about it. Or nobody in Newfield's gotten this, so I can't get it because I live in Newfield. We really needed everyone to be taking the same precautions. I can tell you, if you're interested, tomorrow evening at the legislature meeting, and I don't even know if Shauna knows we're doing this yet, we are going to do a demographic kind of explanation of cases to date. Because we do have 130 plus cases now, and we can kind of share the totality of that without necessarily impacting anyone's privacy. And I know we've been asked that question by a lot of people from day one, but I feel pretty strongly about protecting people's privacy. So I don't have a lot of information about, how people work, but suffice it to say, we have less than 30 active cases currently here in the county.
That's good.
So it's a very small population of folks. As far as the antibody testing, logic would say that if you have antibodies in your system, there should be some protective factor. We don't know for certain what that is yet, Stu. So I wouldn't tell anyone, excuse me, tested positive for the antibodies that somehow they're safer than others. We just don't know that yet. And we will eventually know it as more testing gets done. And unfortunately, the likelihood of a second wave and being able to compare that to people with antibodies and, whether or not they got it again and or had less severe symptoms. So time will only tell as the science evolves around the world. But, as I said, we don't know what the antibody test means today. We likely will in the future. And so there is some validity in beginning to test folks for it. But there's also the challenge of not so good tests being sold out there. And we don't want to give people false information. So until we're sure we have the capacity to provide a high quality, highly sensitive test for antibodies, we're not asking widely for people to seek antibody testing.
Okay, thanks.
Jed, I saw your hand when Susan was answering. Did you want to add something?
Sure. I think that, let me get my mic down so you can hear me. Yeah, I think that this, one of the unforeseen consequences of the use of telemedicine with us in psychiatry, probably universally, is that people are going to be demanding it as an option in the future, and rightly so. And I think that my own experience has been that it's still not, in my mind, as good to do a Zoom evaluation as having the person sitting in front of me. But given that some people can't sit in front of me or, choose not to, or can't find parking, even something mundane like that, the availability, our ability to see more people is going to really be much improved by this. And one can only hope that the powers that be in OMH and the insurance companies continue to allow us to work this way. Like Susan was saying, my no-show rate has been pretty low most of the time because people realize that they may not have another opportunity to see me if they miss their appointment. But my no-show rate with this crisis has been even lower. And but what it points to is that there's a deficiency in technology among people that we see. There's many people who don't have, you know, adequate phones, even who certainly don't have computers with Zoom, you know, who don't have minutes on their phone, you know, who aren't in a place where they can use Wi-Fi, so they have to use their data, which they can't afford. So it brings out another kind of, you know, discriminatory factor among people needing to get mental health services.
Yeah, Jed, that's a really good point. And, you know, a lot of regulations were loosened up very quickly in the face of the emergency, right? And, you know, when you're in an emergency, you do what you got to do. The hope is that, you know, they will not fully tighten down all the way, you know, to the same level they were. Many of them are there to protect the patient. So it's not to say that they're all bad, but it is hope that, you know, as we go back, we don't go all the way back to making it so difficult that you can't do it. And I think there's, you know, another piece to it that Jed hit upon is the efficacy, right? Yeah, we may be having more contact, maybe people are willing to engage, but we don't know for certain if that translates into positive outcomes, right? And so, you know, I'm sure one of the silver linings of all of this is there will be study after study that looks at, you know, the efficacy of telemedicine across the board, mental health, physical health, and others, to see if we have the same end results, and maybe even better because we do have more engagement and less no-shows, right? And is that important enough to sacrifice the face-to-face component of it? You know, as we re-engage. So it certainly will be interesting. And I'll hand it to the state. As much as I normally don't like to say really good things about them, they loosened up quickly. They recognized what we were dealing with, and they said, go make it happen, and, you know, do your best. And it's important that you continue to provide services, so find the best way to do it. So yeah, I think it'll be interesting to see how it evolves.
Frank, this is Elise. I have a comment more than a question. So I was really concerned, I'm sure as many of us were, when we saw that the Youth Bureau had to close primarily due to budget cuts recently. And in particular, I'm concerned about the RSS program, the Recreation Support Services program that operates out of the Youth Bureau that provides critical supports to students and youth with disabilities, in particular in the summertime. And I guess my comment is that I think, you know, if to whatever extent any summer programming gets to operate this year. And I know that there are some summer camps who are still enrolling with the hopes that after a certain point, it may be safe enough to have day camps. I think there's going to have to be an effort, because this has been an ongoing issue for forever, you know, in this community and many others, that there's a misunderstanding about camp's obligation to accommodate children with disabilities at camp and to reasonably modify environments or policies or procedures in order to be able to have campers with disabilities with or without a one-on-one aid. And so I think the RSS program often filled that need, where they would provide, you know, staff and assistance, or they'd provide camp slots for kids with disabilities. So my concern basically in a nutshell is that even though all parents are going to be struggling this summer, I think the parents who have children with disabilities are in dire need of some answers, and then potentially have more of a critical childcare gap than others.
Yeah, it's a great point, Elise. And summer camp has been the question of the day for probably since last Thursday. I think I'm getting asked that question by everyone that looks at me. Are we going to have summer camps, particularly with schools not coming back in and the uncertainty about summer school and summer programming with the school districts? We are planning to get together. It's on the top of my list for tomorrow morning to coordinate a meeting of camp leadership sometime this week to have a conversation. They want me to tell them when they're going to be able to open, and I'm going to disappoint them by telling them I don't know. But we still want to, you know, kind of have an understanding of what planning is going on out there. What's the drop dead deadline that decisions have to be made? And one thing that has bubbled up pretty quickly is high risk kids, right? Of a varying degrees, everything from those with disabilities to those in abuse situations, all of those type things. And that if we're going to have reduced camps, we need to make sure we're prioritizing those high-risk kids to give them an opportunity. Everything from respite from the parents to cut down on domestic violence and child abuse situations to, giving the kids an outlet to get out and be away from what might be a dangerous situation for them. So, yeah, I hear you. We're definitely talking about that, and it's been a hot topic the last few days, and we're hoping to have some conversations in the coming days. Ultimately, it's the governor. Again, I hate to keep pointing the finger at him, but we're following his lead on when he wants to do these things. And the challenge that we face is people are saying, I need 2 months to plan to open my camp. That's not going to happen this year. If you need 2 months to plan to open your camp, you're probably not having camp, because we're not going to be able to give 2 months notice. We're doing this week by week and almost day by day. So that's part of what we want to talk to them about and help support them in any ways that we can, so that if the opportunity does present itself to provide summer camps, that one, we have outlets for high-risk kids, and two, that we can support the camps in providing as much service as is reasonable, both with the short timing for planning as well as safety related to the disease.
Great, thank you.
Paula, you guys are so good about raising your hands.
I don't know if you've covered this already, because I actually got bounced out of the meeting for a while.
Oh, sorry.
Yeah, I don't know what happened. What's been done to protect the jail population?
Yeah, so the jail population is very small. It's been under 30 people for weeks now. So that's a good thing in that there's not a lot of people in the jail. It also means there's space. So new folks coming to the jail, of which there aren't many, are screened by the medical staff there, and then they are quarantined for a period of time when they first arrive. And because there's so few people in the jail, they're able to do that segregation to prevent any potential exposure. So the jail has procedures for monitoring for symptoms. They have masks to provide to the folks that are in that quarantine phase. And so thankfully we've had a really good process there, largely in part because we have space because there's so few inmates there. Okay. Other questions? Jan. You're on mute, Jan. Nope.
Yeah, I just wondered, it's probably too early to say, but it sounds like the staff have been really busy and doing a great job. But I wondered if you anticipate that there'll be a financial issue due to the virus at TCMH.
Yeah, so I can't talk a lot about that part of things. Jason Molino, County Administrator, will be giving a presentation to the legislature tomorrow about his plan related to that. So I would encourage you all to watch that if you're interested. It's the normal ledge meeting at 5:30 tomorrow. There'll be a YouTube link that you can watch. I can tell you, in talking with Jason, he recognizes that there is going to be a demand for mental health services as this continues to evolve, and he's taken that into his decision making as we're navigating these uncharted times. So tune in tomorrow to get more detail about that. But I think the mental health department will be prepared and ready to meet the need when and if it increases.
Okay, thanks.
Other questions? All right. Well, just to kind of do some summing up, a couple of things. I will be working with Karen to get the subcommittee meetings set up for this month. They're not going to be as elaborate as this with the YouTube link and all of that. I do have a Zoom license that they're never getting back from me. oh shoot, I forgot Lauren and Greg were on, that we'll use to have those subcommittee meetings for this month. And then, because I'm going to try to attend all three, if I set it up with my license, I have to be there. And I do plan to be there as long as things don't change, which they might. But we'll have Zoom meetings this month, and then moving forward, we'll talk about how we're going to have Zoom meetings or some other type of mechanism to have those meetings. The county has given guidance. There's 3 boards that have legal requirements. This one, the Board of Health, and one other one that isn't my responsibility, so I never remember what it is, that has to have public meetings because of your responsibilities. And so Greg and Lauren have thankfully helped us this month to make this happen in the fashion that it is. We'll see, depending on where we are from a meeting perspective for next month on how we move forward with this. But for the subcommittees, we're kind of on our own to figure that out. So between me and Karen and the chairs, we'll figure out a process to allow those meetings to occur. So we can give updates and hear a little bit in more detail from some of the partners, contract agencies, and others that are probably listening on YouTube right now to be able to talk about what's going on with their agencies and what they've been able to do to give you more detail. So stay tuned to hear about how we're going to be doing that. Jeremy, you had raised your hand earlier and I missed you. I wanted to give you an opportunity to weigh in.
I just wanted to say they made it sound really good and easy because they're really good staff, but the amount of work that went in those first 3 weeks from the staff you see here and other staff that you don't see was tremendous. The changes were happening every 5 minutes. We thought we'd have something in place. We'd have to adjust it. The building would need to have something changed in it to keep each other safe, to keep clients safe. It was gigantic. And I'm very proud that I got to be a part of this team, and I'm very proud of what we did. They blew it away. I mean, we have clinicians at home who put together how-to videos so that they could help each other figure out Zoom, or they could figure out how to sign into something. Like the amount of people that it took, including support staff, including billing staff, including other administrative staff, it was really well done. And when you consider we're missing positions, these people filled all of those positions and more. So I just wanted to throw that out there because it was really a beautiful thing. And we were able to offer all of our services almost immediately to anyone who wanted them. And that was pretty awesome to watch. So I just wanted to say that publicly in front of them too, because it was a lot of work.
Yeah, no doubt, Jeremy. Yeah, it's sometimes we've been in this for a few weeks now and you forget how ridiculously crazy it actually was there. And it is no joke that there'd be 5 minutes apart and the guidance would change on what we should be doing. And the lift that the team did was absolutely amazing. So thank you for sharing that, Jeremy. I want to share one quick story, kind of a happy note in all of this. I don't know how many folks are aware, but part of what we've been doing up here is standing up an operation to coordinate cloth mask making for the community. There was grassroots efforts going on that have been really, really strong, but they were just kind of missing that piece that could bring it all together. And the county felt like that was a role that we could do. So I kind of took on that process. And one of the things that we did was Cornell and the hospital had been making masks at Bartle Hall from the beginning, surgical masks for the hospital, and they've been making thousands of them. And so we're like, oh, well, we'll just piggyback on that and we'll start making masks. Well, it's not quite that simple. And it turned out that they had pretty much taken all of Bartle's Hall, the gymnasium there. So there was no space for us. And one of the reasons we wanted to go there was to piggyback on their infrastructure to say, hey, you did all the heavy lifting figuring this out. We'll just come in and start making masks next to you. So we had to go to another location, which turned out to be the TST's BOCES gym. And they were super helpful about letting us get set up. And myself and Bridget Nugent, who's the deputy director for youth for the county, were kind of tasked with getting this up and running. And neither one of us has ever touched a sewing machine. In fact, she brought her home sewing machine up and just left it up there because she's like, I haven't ever touched this thing, so I don't need it. But what we needed was someone that knew how to sew. And Julie Dickens, who's a community mental health nurse that works in our QAI group and works part-time with pros, had been sewing masks for staff at the department. And when I started looking around for someone to help us, her name bubbled up. So I called her and she was like, this is a dream come true. I get to sew all day long and get paid to do it. So we've affectionately dubbed her our lead seamstress. And I don't know that we're ever going to get her back to being a nurse again. She is so happy. She's been teaching all the other sewers the pattern. She's so excited that she actually gets to teach people how to sew. She's like, I didn't know I knew how to sew that well. And so she's led the cutting operations, getting materials and all of that. So she's been doing an amazing job up there. I think for Heather and Jana, who are going to want her back someday, we're going to have to ply her with all kinds of treats and things because she's pretty happy doing sewing up there. So it was just a pretty, a funny story to see it unfold that way. And it's just another example of we called, said we had a need, and she stepped forward. And that's been an example of what's happened with county staff from the beginning of this. And I echo Jeremy, I couldn't be more proud to be a part of the team here at the county that has navigated both at mental health, public health, but even as a broader community resource through all of this. So, as board members, I hope you're equally as proud of the work that your staff and team are doing. And we look forward to continuing that work. So with that, I'll turn it back over to you, Mary, for final words.
Yes, thank you so much, Frank, for such a complete presentation, and to the staff. It was really helpful to understand more about what you're doing and how the whole process unfolded. And we appreciate the information. It's fantastic. So as Frank described, we're going to kind of see what's going to happen next month for our meeting, but chances are we may be in the same kind of format. But I appreciate everyone coming, and we'll meet again soon then. Thank you.
Thanks, sir. Jan, did you have a question?
I just wondered if we were supposed to be doing the minutes.
We'll do that next month. We decided for this first one, we just leave it to kind of updates. We'll get back to a regular agenda next month. We probably have like 6 months worth of minutes. We're having struggles with quorum. So we'll get through that, and we'll figure it out for next month.
Sure.
Okay.
I think we got a quorum today.
We did have a quorum today, right? So hopefully we can pull that off again next month.
Okay.
All right, great. Thanks, everyone. Have a good night and stay safe.
Good night.
Thank you.